Good morning, everyone. Welcome for today's lecture on troubleshooting diabetic children. I'm delighted to see such a great turnout of participants eager to learn and engage with this important subject. Today's session will be a comprehensive approach to on-call management and foster discussions that will enrich our understanding and practice. If you have any questions, feel free to unmute yourself or add your question to the chat box. Let's make the most of this opportunity to learn from each other and from our esteemed speaker. Our speaker today, Dr. Mohamed Khair, is the sixth pediatric. He was graduated from University of Khartoum in 2014, then worked in different Sudan hospitals before moving to Ireland in 2018, and then joined the training with NHSC in East Yorkshire Deanery in 2019. He started his spin diabetes training in 2023, and this year he is completing his postgraduate diploma degree in child health from University of Leeds with optional module uptake on teaching and education. Thank you, Mohamed, for joining us today, and the mic is yours now.
Hi, thank you for the introduction. Thank you very much. Good morning, everyone, and thank you for joining me on this session. I hope it's going to be as useful as it can get when it comes to tackling issues with children with diabetes. Let me just check, first of all, can you all hear me? Is it all good, audio? Can you see the presentation?
Yes, we can hear you, and we can see the presentation.
Brilliant. So let's make a start then. So hopefully by the end of this session, we will have more understanding of how to prescribe subcutaneous insulin in children newly diagnosed with type 1 diabetes. But also have a better understanding of what is the current technology for glucose monitoring and what kind of devices do we have now that we use to monitor blood glucose in children with type 1 diabetes and type 2 diabetes as well. And hopefully we'll also know what's the recent updates of technology in insulin delivery and how to understand how they work. And combining those two information and knowledge that we have, hopefully we'll have a better understanding of how closed loop system works and how we can use the information to make children with diabetes have a near normal life and to prevent the long-term complications of having diabetes. At the end, we'll go through a few scenarios that hopefully will work as a survival guide when you're on call and you are confronted with a concern or health issue related to type 1 diabetes in children. So how to prescribe subcutaneous insulin in children newly diagnosed with type 1 diabetes. Few facts before we go into that. So subcutaneous short-acting insulin is prescribed for newly diagnosed patients not in DKA, or sometimes even patients who need adjusting of the insulin because of the glucose control is not at the best. But the key message is not in DKA. So if they are on DKA, we follow the DKA protocol. So you have to establish with each new presentation from the community or from a concerned mom or whoever who comes with polyuria, polydipsia, or being drowsy or vomiting or anything, that first they do not have DKA before you prescribe them subcutaneous insulin. If they have DKA, of course, they will have the IV insulin and they have to go through the DKA protocol. When it comes to long-acting insulin, however, there's a change recently that those who are in DKA, they can have the Tresiba or Nuclogag or whatever long-acting insulin that you use in your unit on the evening of the admission. So despite being on DKA protocol, they can also have the long-acting insulin to help them. And it's proven to shorten the HDU stay and help faster glycemic control and have a faster normalization of care. They start eating, vomiting stops, and glucose comes back down nicely and gives them this smooth background insulin that helps them control their glucose for 24 or 36 hours, depending on what long-acting insulin they're having. Insulin prescription error is a never event. And when insulin is prescribed wrongly, I don't know if you've been through this, but if a doctor prescribes insulin and it turns out to be not the wrong dose or not the wrong form or even the wrong route, the DETEX generates automatically in the hospital and education comes along. So please be so vigilant and be careful whenever you prescribe insulin. And if you are in doubt, just go to someone who knows. Go to your senior doctor, go to a diabetes team member, or even sometimes the ward sisters and nurses, they know how to do that. And they will tell you what's the right way to do it. So always, I always double check. Even after I prescribe it, I double check with the nurse, make sure that she's happy with everything and she understands what the prescription means before I give it back to her to give the insulin to the patient. And this goes for subcutaneous and intravenous insulin as well for patients who are in DKA. So just be careful. So most patients in the current practice who have type 1 diabetes and who are on insulin, when they meet multiple daily injections, MDIs, i.e. not insulin pumps, they have a combination of two types of insulin, the short-acting and the long-acting. The long-acting is usually the evening dose that they have that covers them for 24 to 36 hours. And the short-acting is the insulin that they have before they have their meals or to correct their high blood glucose readings. Sometimes we refer to these two styles of insulin as bolus insulin and basal insulin. So the basal insulin is the insulin you have in the evening, and it gives you the background insulin that you need for your physiology, basically. And the bolus insulin is the insulin you have as a bolus with meals or with high blood glucose to correct the blood glucose back to normal. The long-acting currently in the market in the NHS are the Tresiba and the Digludec, and the short-acting are the Fiasp and the Novorapid. There's a whole topic of types of insulin, how they work, when they spike, when they start working, but this is not out of the scope for this session, so we'll just keep it as simple as it is when it comes to these types of insulin. Prescribed insulin, there is few terms and definitions that are helpful and it's good to know. One of them is total daily dose. So total daily dose is the estimated total amount of insulin that your body needs to function, basically. And it is both the basal insulin and the bolus insulin. So roughly speaking, if you have 6 units of Tresiba every day, and you have about 10 units of short-acting insulin, like 3 for the breakfast, 3 for the lunch, and 4 for the dinner, your total daily insulin is 3 plus 3 plus 4 plus 6, which is 16 units per day. So it's whatever insulin you need on the whole day to maintain your blood glucose is called total daily dose. The breakdown of this is there's an insulin carbohydrate ratio, which is how much insulin you need for every gram of carbohydrate you take. So let's say if your ICR is 1 to 12, this means that your body needs 1 unit of insulin to handle every 12 grams of carbohydrates, which also means that, for example, if you're having a meal that contains 42 grams, the quick math, you will need 3.5 units to cover this meal. It is clear.
Yeah.
And then there is the insulin sensitivity factor, which is how much the drop of glucose you experience for each 1 unit of glucose you take if you're not taking carbohydrate. And it's basically how sensitive your body is to insulin. So if your blood glucose level is 18 and you want to bring this down to 10, and your ISF is 1 to 8, this means that you need 1 unit to shift your glucose from 18 to 10. And this is how we prescribe the insulin. So in a drug chart, if you open any insulin drug chart for a child who's having insulin pens or insulin injections, you'll find the insulin prescribed as ICR, ISF, and long-acting. And bear in mind the ICR and the ISF, the carbohydrate ratio and the sensitivity factor, these are bolus or short-acting insulins. So how to calculate them? These are all estimates, bear in mind. And the purpose of this is when you have a patient who comes newly diagnosed with diabetes, you know the start point, you know, to have a point to start with. And then you can adjust all of these ratios depending on how they respond and with this glucose monitoring over the following days. So total daily dose of insulin is half your weight, and your long-acting insulin is half that total daily dose. So that's quick. So the insulin carbohydrate ratio is 300 divided by your total daily dose. And for those who are younger than 2 years, always check with a doctor who has an idea about diabetes, because of their small weights, they end up with ridiculously high ICRs, 1 to 80, 1 to 70, or even sometimes 1 to 100, which means that a small change in the insulin can result in massive changes on the glucose, either up or down. Plus, this age group is very tricky to trace their meals. Sometimes you make a meal, they don't take it, and they have the insulin already. So always, most of them end up having a fixed regime, fixed units, like 1 unit with each meal, or half a unit with this and half a unit with that. So always just check with the diabetologist, because it is a bit different, this age group. The ISF is 120 divided by the total daily dose. Now, some references use 100, but let's just use 120 for the sake of this. I think it's the safer to use 120. It gives you more flexibility, and this is my experience. So if you have a patient, Lucy, who's 9 years old, who came to the PAU with classical symptoms of diabetes, polyuria, polydipsia, and weight loss. Her blood sugar was found to be 18. That's why the GP has referred her to you. And when she came to PAU, she was found to have 80 millimoles per liter. Her ketones are 0.1. Her blood gas is unremarkable. So is she suitable to have a subcutaneous insulin? And if she does, what's her total daily dose and long-acting dose, and what's her ICR and ISF? And this can be a real life scenario. So I don't know if people are happy to pop in the chat what they think, what the calculations are. Do you want me to go back to the slide of calculations, or? Yeah, she can take subcut insulin. Her weight is it not there? Okay, so her weight is 30 kilograms. Yes, so her total daily dose is 15. And lock acting in 7.5. Yeah, so we're having very good response. So yeah, some people have already replied. Thank you for those who are replying. Thank you very much. So yeah, her total daily dose is 15, and her locking 7.5, and then come to her ICR and ISF. Yeah, thank you, guys. Thank you very much. So her total daily dose is 15. Traceba, you're right, it's 7.5, but sometimes the practicality, so the pen of Traceba does not provide 0.5 units. So she ends up having either 7 or 8, and you can choose. So let's give her 8. for placebo dose. Her ICR is 1 to 20, and her ISF is 1 to 8. So thank you for those who replied. And so she's having a meal in the ward, and for her T-carb counting, she's having 60 grams of carbohydrate in the meal. Her pre-meal blood sugar is 16, and her target is agreed to be 4 to 10. And how much insulin should she have? So if you want to correct her blood glucose to 10, let's say, just giving people time. So for her meal, we cover her carbohydrate unit. We cover her carbohydrate meal because she needs the ICR to cover her carbohydrate. 60 grams divided by 20 because her ICR is 1 to 20. So she will need 1 unit for each 20 grams. She's having 60 grams. This means that she needs 3 units to cover for her meal. Also, she needs to correct her blood glucose, as we said, from 16 to 10, which means that she needs to cover for 6 units. And if her ISF is 1 to 8, this means that she needs 4/4 of a unit to make the jump from 16 to 10. So approximately 1 unit. So in total, she will need 4 units. Those who say 5 units, yes, sometimes we just give them more, 4 to 5. And remember, it's all estimates. So after we give her the 4 units or the 5 units, she will have her meal, and then she'll have another blood glucose level before the next meal, and that blood glucose will tell you whether she's had enough the previous meal or not. Does this make sense? So those who said 4 units, you're right. Those who said 5 units, you're right. And this has to be a bolus insulin just for correction and for her meal. So that's about prescribing insulin, and just a quick example, a real life example of that. Is everyone happy with that, or do you have any questions in that topic?
Could you repeat just how you calculated the correction?
Yeah. You mean the ratios or the insulin dose?
The ratios.
Okay, so we assume that her weight is 30. So if her weight is 30 kilograms, her total daily dose is half that. So I'm just showing it, sorry. Yeah, so half 30 is 15. And the placebo dose, which is the long-acting insulin, is half total daily dose. So 7.5, but we just approximate this to 8 units. Then the insulin carbohydrate ratio is 300 divided by your total daily dose. So 300 divided by 8 is, I don't know how my calculator, but it comes out to be 1 to 80. And the ISF is 1 to divided by 8, which comes to 1/8. So all the, yeah, they're here. Does it make sense? Oh.
Yeah.
Yeah. So this is the slide you need to know. And this is your guide basically to prescribe the initial doses of insulin. Any further questions?
Dr. Mohammed,
Yes.
is the
Is someone, sorry, did the line cut off or?
Okay, yeah, sorry. And
Yeah.
I'm asking about the numbers of 300 and 120. Are these numbers standard to keep always in the upper? 300 and 120. What are these numbers?
These numbers came from the studies on the euglycemia of patients who came with diabetes. So they're all
Okay.
estimates, and this is, they can differ according to your local trust guidelines. These are the ones that are used in most of East Yorkshire, but some references use 500 for the insulin carbohydrate ratio, and some trusts use 100 for the insulin sensitivity factor. And
Okay.
some other trusts even goes into more details of classifying them into age cohorts. So they would say like 3 to 5 years, 500, more than 5 years, 300 for ICR, and the same goes for the ISF. So it all depends on the local practice, but they came from, I did a quick look into them, and they just came from the studies back in the days when they started having the insulin, and they started the idea of, let's not give them a fixed dose of insulin, because that's what the old practice, isn't it? To mix the long acting and the short acting, to give them 3 doses, lunch, breakfast, lunch, and dinner. But then when they started changing the approach into, no, let's mimic the pancreas, give them a long acting one and a short acting with meals. So when they converted this idea of delivering insulin, they did a cohort based on the mixed insulin studies, and they came up with these fixed numbers. But as I say, very often we start with these ones, and by the end of the same admission, they go home with different ratios, because we keep monitoring them, and they end up some having different doses, sometimes even for different meals. So you might find their ICR for the breakfast 1 to 8, for lunch 1 to 12, and for dinner 1 to 4, for example, depending on what the blood glucose is. But it's always good to have a starting point, do that, and then adjust accordingly afterwards.
Okay, makes sense. Thank you so much. Thank you.
Okay.
I see there is a raised hand if you want.
Yeah. So this is the calculation of ICR. It is 300 divided by total daily dose. So in that example, so it is 300 divided by 30, isn't it? Then it comes to 10.
300 divided by 15. Total daily dose, 30 is the weight, Sudashi. So the total daily dose is half the weight, it's 15.
Oh, yeah, right. Okay, yeah.
Yeah, and
Thank
then
you.
ICR is 300 by 15. Does it make sense now?
Yeah, thank you.
Okay. Any further questions, guys?
Yeah, please, this ISF, I cannot understand. ISF.
Yes. So ISF is insulin sensitivity factor. So it's how sensitive your body is to insulin. So if your ISF, let's say, is 1 to, for this example here, and this slide is 1 to 8, this means that if I give you 1 dose of insulin, this 1 unit of insulin will shift your blood glucose down by 8 millimoles per liter. So if your blood glucose is 20, for example, and I give you 1 unit of insulin, and your ISF is 1 to 8, this will shift your glucose from 20 minus 8 to 14 to 12. That's the idea of ISF.
Thanks, yeah, it's clear now.
Does it make sense?
Yes.
Yeah, thanks.
Yeah. And we'll be using these terms in the presentation very frequently, just to fix the idea of them. Okay, so if there's no more questions, let's talk about technology that we use for continuous glucose monitoring. So how do sensors work? Sensors are the big jump in diabetes management. It's not the pumps. The big jump actually happened with the CGMs. They are the pivotal point in management of diabetes, especially on those with type 1 diabetes. The pumps came afterwards, and they changed with the pumps with just tweaks of technologies used in other domains. But the idea of having a continuous reading, or sometimes even intermittent reading of your blood glucose levels without having to prick yourself, has encouraged patients to have an idea about how much to have in their mind regarding their meals and what's the level of the glucose they have in mind without having to prick themselves. So they were more keen into observing the blood glucose levels and acting accordingly. So the current technology of having the sensors, there's three parts basically of the sensor that works, principally speaking. There is the sensor, the transmitter, and the receiver. So whenever you have a sensor attached to your body, this sensor checks the blood glucose, not in the blood, it's very important, but in the interstitium. And they have found that those two levels correlate very tightly. So if you have high blood glucose in your blood, you will end up having high blood glucose in your interstitium and vice versa. So the sensor checks the blood sugar in your interstitium, send this to a transmitter that's usually attached to the center, and the transmitter sends these signals to a receiver. And the receiver can either be an application, an app phone with smartphone these days, or historically, when they started this idea, it used to be a device that comes with a company that you scan the transmitter with, and it's a screen that gives you the reading. So if you have old-fashioned sensor, you will scan and it tells you, okay, 6.8. 30 minutes later, okay, it's 10. 30 minutes later, it's 12, and so far and so on. So the three parts are sensor, transmitter, and receiver. So a sensor detects the glucose concentration in the interstitial fluid, then transfers the information to a transmitter that sends the data to a receiver. And this can either be a reader device or a smartphone. There are two styles of glucose monitoring. There's the continuous glucose monitoring, CGM, and there's the flash monitoring. So as I've just said, the CGM sends continuous signals, okay, every 5 minutes. It's the most modern sort of it. Every 5 minutes sends continuous readings telling you how much glucose is without you having to do this scan. So if you have your app, or most of children you've seen probably with diabetes have this CGM one. So it just sends the messages to the application phone. They just open the app, look at the screen, they know what their blood glucose is. The second style is flash, in which you have scan transmitter with a reader on the mobile phone to obtain the blood glucose real reading. So this is the two kind of two styles of that. Then with this in mind, can you see this picture? So this little girl is having this sensor, this glucose monitor. Having a CGM, as I say, has had great advantages. So less finger pricking, easy glucose monitoring, and the modern ones have this feature of what's called predictive alarms. So if you have met a patient in hospital who's having the Dexcom Clarity app or Libra app, it does not only tell you what the actual blood glucose is only, but also tells you whether it's going up or whether this is going down. There's an arrow attached to it. This is called predictive alarms, and it makes you more proactive than reactive. So if you have diabetes and you have Dexcom G6 sensor in your arm, and before you go to bed, you look at the app and it tells you your blood glucose now is 5, and there's 2 arrows going down, this means that you're probably going to be hypo overnight. So before you go to bed, you eat a snack, for example. That makes you proactive rather than reactive. And this prevents you from having the hypoglycemia symptoms, or the other way around as well. So if your if your sensor is telling you that it's 15, 2 arrows up, this means, oh, be careful. Maybe you need to check in again in 5 minutes. Maybe you need to have some correction dose of insulin. And this is the real change in diabetes management. And this is the real change that made patients having more percentages in target are these sensors. But Can you think of any downsides of that? Let's see. What do you think, guys? Having a sensor, can it be challenging in any way? Can you think of any? Yeah, could be stressful, yes. So having a sensor sometimes makes your mind busy. But if I have this facility, how can I best use it? Especially with those with very perfectionist attributes. Could you give wrong alarms? Yes. Sensor can be broken. Needs checking with extreme levels with usual methods. Can be faulty, just like any other device. You're absolutely right. And can give you your own readings. That's all nice. Thank you, guys. Thanks for interacting. So you're absolutely right. So there's a lag in readings. Remember what I told you about measuring the glucose in the interstitium only, not in the blood. But what we're actually treating is the blood glucose level. So it's estimated there's 15 minutes lag of what the sensor is telling you and what the actual blood glucose is. There's 15 minutes lag, which means, yes, it says it's real time, but likely this reading is 15 minutes ago. And this is where come the advantage of having the predictive alarms that tells you whether it's going up or whether it's going down. But always bear in mind that there's a lag in readings. And this is why, if you go to the very bottom one, it's not very accurate in extreme readings. So if you're having a sensor telling you that blood glucose is 3 or 2.5, the advice we give to patients is finger prick, because that's the actual blood glucose, and double check that. And likewise, if it has been 15 1 hour ago, and suddenly it tells you that your blood glucose is 30, finger prick, I'm not sure what the actual reading is. And it is by the BSAPCH guidance that every patient who has a sensor must have ketone reader and a glucose reader, the finger prick, when they need. Inconvenient to some children, especially the small children, the 3 years old, 4 years old children, it's inconvenient to them because they slip, they don't like it, they poke on it and it breaks, it's not reliable, it slips, doesn't give you a reading, it's faulty. Some parents just do not prefer them. And the other extreme of population, the teenagers, sometimes they opt out of using them because it exposes their diabetes. So sometimes they're not happy sharing that they have diabetes with their friends, with the public, so they don't wear the sensors just because of that. So this table shows you the wide range of sensors that are available out there. But let's just be focused because there's too much to cover. So the 4 ones that probably you've come across are the Libre 2, Libre 3, Dexcom G6, and Dexcom G7. And they're all funded within the NHS, and they're all within the diabetes service for children. Now, with these options, which sensor for which patient? So not how to choose the appropriate sensor for my patient. In left-hand side, you can see a different range of criteria and features, but I'll just highlight the most important ones that helps us to choose which sensor for which patient. The first thing is real-time CGM. So does this sensor provide a continuous glucose monitoring, or is it like the flash type? And we prefer the continuous glucose monitoring, of course, because it gives us more information. As you can see, almost across the board, they all say yes, but the Freestyle Libre 2 historically wasn't that, but they have updated the technology with an application that you can put to Libre 2, and it gives you this continuous readings. So now all of them have this feature of real-time CGM. And as I said, when they see a real-time CGM, they mean the ISF, interstitial fluid glucose, not the blood one. So it doesn't mean that you don't have to check on the extreme ranges. You still do have to do that with all these types of sensors. Predictive alarms, which we talked about. So not all of them have that. As you can see, Dexcom 6 and 7 does have it, Libre 2 and Libre 3 does not have these features. As I say, some patients prefer to have alarms, And some patients prefer not to have alarms because it's just too many alarms in this, overwhelming to them, especially when you run hypo overnight and it just beeps on your head in the 3 a.m. or 4 a.m. in the morning. Bear in mind, you can, if you're using an app, smart app on your phone, you can disable this feature with the Dexcom companies also. It's not a must. It's not like you have to have the alarms with these types of sensors. Closed loop compatibility. For you to have a closed loop compatibility, it has to be a CGM. So Libre 2 cannot be in that. So this is why Libre 3, Dexcom G6 are the ones that are compatible with the closed loop system, which we'll talk about later in this presentation. So based on, and then the UK approved wearable site. Arm, universal, abdomen, not all of them. Dexcom can go there, but not the Libre style. And this is, again, as per how young is the child, how old is he or she, and what's the preference of the family for that. So based on these and other factors and other features and open discussion with the families, loads of leaflets, you get to choose what sensor you need to go for, if any, because some don't. Any questions?
For the selection of this technology, is the diabetic team making decision for particular selection to particular patients, or it's like just the parents' decision to select which one?
It's more of a shared view. So when they have their first appointment after having diabetes, so if a child comes with newly diagnosed diabetes, the first appointment happens usually within 2 weeks. So in 2 weeks, the conversation starts basically, and they'll be provided all the leaflets for all the available sensors, and they will be told the same talk about what's good in this one, downside of that one, and this and that. Another thing is how often we change the sensor. Some of them are 10 days, some of them are 14 days, some of them are 3 weeks. So it depends really, and then it's a shared view between the family and the doctor and the diabetes team, not the doctor only, but the diabetes team. And there's other factors outside medicine, like the supply and NHS now, the cost of things is the voice of that is getting louder and louder. And the insurance of continuous supply, because we don't only have to, probably we have this for life. So the continuous supply of the company and how much the company has now, the guarantees, the warranty and everything. So it's a big discussion, but that's the main pivotal points when you discuss the availability of which is which, basically.
Okay, thank you so much.
So Abdul is asking how accurate the interstitial reading compared to blood. It is accurate, Abdul. It's just late. It does give you the reading. It's just late. So if you are within range, that's not a problem. Like if it tells you that your blood glucose is 8, 10, or even 13 or 15, it's fine. But if it tells you your blood glucose is 2, when you do not have any hypoglycemia symptoms, just finger prick and check. And when it tells you that blood glucose is 30 in the morning, when you have not had anything to eat yet, just double check. So there's just a lag, but if the sensor is functioning, it's fairly accurate. So, any further questions, guys? Good. So far so good. So what is the current technology in insulin delivery? So let's talk about insulin delivery now. Of course, we have the conventional pens that usually comes in pairs, one for the short acting, one for the long acting. But now we also have the insulin smart pens, and we have the pumps, which I'll talk about in a second. So what is a smart pen? So a smart pen is very similar. You can see the picture, conventional insulin pen. It just has some extra features. So it automatically records the dose of insulin given and the time of that dose. In the pen itself, in the very top of the pen there's a small screen that you can click, and it tells you how much insulin was given, like 6 units, 10 units, and it tells you when it was given. It's easy to use because everyone who can use a conventional pen probably can use a smart pen. It's the same way of giving the dose, changing the cartridge and everything. And it can connect to an app that helps you monitoring, which is this very, very nice feature, because it gives you an idea about the trends. So if someone suddenly started having higher dose of insulin, you should need to think about why is he having that, and the other way around as well. And if someone comes to the clinic with a poor control of diabetes and rising HbA1c, if he has a smart pen, you can just log into the app, see how much he's having, and if he's having, let's say, per day, 1 insulin dose, probably he's not having enough. Probably he's just having the insulin for the lunch and he's skipping breakfast and dinner. So it gives you an idea, and when you confront them with that information, it helps planning further management and helps them to be more open about difficulties they have about the insulin administration or anything else. And then you can address these issues, control the blood glucose. We've once had a patient who comes in with an unexplained hypoglycemia, and they just come in with this. They are in insulin, type 1 diabetes, and they come with unexplained hypoglycemias. They absolutely adamant that they're having the insulin as prescribed and when it's prescribed. But when he was given a smart pen, we found that he's overdosing his insulin as part of self-harm. So it's useful. It's a very useful technology. But at the top of the technologies, of course, is the continuous subcutaneous insulin infusion with the insulin pumps. Bear in mind, they only use fast-acting insulin, the bolus insulin, either the Fiasp or the Novorapid. Is compatible with the hybrid closed-loop system, and this is why they are of a big preference in smart pens. They need to be worn most of the time for maximum benefit, which can be challenging to some patients. And for example, if someone has a pump, they have to take it off for a bath, put it back on, have to take it off when they go swimming, put it back on. So this on and off kind of activity sometimes can be annoying to some patients. It's proven to improve HbA1c, time in range, and the psychological health of the users. And this is why we strongly kind of recommend them. And the RCPCH current guidelines is every single patient with type 1 diabetes has to be offered the chance to use insulin pump. Whether they use it or not, it's a different issue, but they have to be offered insulin pump to use because of these benefits. Can sometimes be overwhelming, because if CGM is overwhelming, how about pump on top of that? Prevents early morning hypoglycemia down phenomenon, which is really useful, because we know that from studies that with you in early morning with your anti-insulin hormone spike, the cortisol, growth hormone, everything, every patient with diabetes tend to have this hypoglycemia in the morning. And if they eat breakfast and they're not correct, they continue to be high for the rest of the day. So the insulin pump, if used with this closed loop system, it does prevent this early morning hypoglycemia, which in the long term does help bring down HbA1c, and in the longer term, it reduces the risk of having diabetes complications. Insulin pumps. So they deliver insulin in 2 ways, as we have said, basal insulin and bolus insulin. So basal insulin is the insulin that runs in the background automatically without any input from the user. It can be seen as insulin hourly rate, like units per hour. In the closed loop system, it can increase, decrease, or even stop based on the expected blood glucose level reading. So it's very important to understand the idea of the basal insulin. So the pump, if not on the closed loop, it will deliver the basal insulin anyway. Whether you're having meal or not having a meal, it will give you this basal insulin. And on top of that, you have to ask it to give you the bolus insulin. So is the insulin that the user takes, ask the pump to deliver, either before meals or to correction, which is the ICR that we just talked about at the start of this presentation. Can also be given by the pump in the closed loop system to correct spike in hypoglycemia or to bolus. So you have this basal insulin, and before you have your meal, you tell the pump that I'm going to have 40 grams of carbohydrate. And for these 40 grams, my ICR is 1 to 8. So I need to take 5 units, please. Can you please give me 5 units? And it gives you the bolus insulin. Or you wake up in the morning, you check your blood glucose, it's 25. and you need to correct it from 25 to 10. So please, can you give me this bolus insulin for ISF to correct my blood glucose? And it gives you that. So you have to ask the pump to give you the bolus insulin. Even if you're in a closed loop system, you have to ask the pump to give you the bolus insulin. The pump deals with the basal insulin in the background, either to give it, increase it, decrease it, or stop it. But it cannot handle the bolus insulin. You have to ask it to do that. We are yet in technology to reach a full closed loop system. We are yet to reach that point. It's hybrid closed loop system. So it's hybrid between the user and the algorithm. So you have to ask it to give you the bolus insulin, and it will handle the basal insulin for you. Does it make sense? Sometimes, if blood glucose spikes very high, the pump does give you what we call auto boluses or mini boluses. So it gives you a spike in the basal insulin that can be considered a bolus insulin. So it just increases and goes back, but this has a limit. It cannot go above 20% of the basal insulin. Most of the bolus insulin, the user asks the pump to give. It's very important to get this, guys. So let me just check. Do you understand this idea? Because we'll come to that over and over again in the next presentation.
Can you repeat again?
So the insulin pumps deliver insulin in two ways. The basal insulin, which means that the insulin gives you that basal insulin in the background without input from the user. It does give you that. And the pump, if it is connected to a closed loop system, will have the extra feature either to increase, decrease, even stop giving that insulin. So if your blood glucose is trending up, it will increase that. If it's trending down, it will decrease that. If it's going really down, it will just stop for some time and then continue again. This is what the pump in the closed loop system can do to you. The bolus insulin, on the other hand, is your job as a user. You tell the pump, I am having 40 grams of carbohydrate. Can you please give me 5 minutes for that? And you press enter, and it gives you that. The same for dinner, same for breakfast. Or you say, my blood glucose is 20. I don't really like that. I need to go down to 10. Can you please give me a bolus insulin to bring it down to 10? And you press, and it gives you that. So it's as per your order as a user. Some smart systems increase the basal insulin a smidge, which can be called mini bolus or auto bolus. But this is not for great effect. Mainly, bolus insulin is the user's job to control, and we are yet to overcome this. And most of the patients who come to us in the clinics with rising HbA1c, that's why they do not, it's a user fault. They do not ask the pump to give insulin. Does it make sense now?
How I will ask the pump to give? I will instruct or how?
I will come to that in the closed loop system. I'll come to that. Through the app, basically through the app. So you just tell her how much grams you're having, and you press, and it's the app, the smart app gives an order and gives you the insulin. Okay?
Okay.
There's two types of insulin pumps. There's the patch pumps and tethered pumps. So patch pumps sits directly on the skin. Okay? And they are attached to the cannula, and there's no tubing system. So it just sits on your body. Because they sit on the body, and there are one-piece device. They are temporary, and we change them roughly every 3 days. The Omnipod 5 is every 3 days. So every 3 days, take it off, put a new one, take it off, put a new one. The tethered pumps, they have a body and a tubing system, a tube that gives you the insulin. And all you change is the cannula, but the pump is permanent. So let me just show you some pictures to understand. So the one in your right, the top here, can you see can you see the pointer? So the one on top here is a patch pump. So it sits on the skin. The cannula and delivery system is attached to the pump, and it's all attached to the pump. This is the only 0.5 pump. So it all goes out and it's replaced every 3 days. This is called patch pump. The tethered pump, the most common type is a T-slim pump. That's the pump. This is the tubing system that goes all the way around. And this is the cannula. So all you change is that cannula, this cannula. Pump is permanent. Now, you can see that the tethered pump, the T-slim pump, has a screen on it. And this screen, okay, is where you do the controls. So you can have it in your hand, and then you can do the controls. You can ask it to give the bolus, give more insulin, reduce insulin, and all the system is hosted in the pump, on the pump, as part of the pump. And all of you change is this. The tethered pump does not have this feature. So it sends the information to an app in a smartphone that has similar features to what you see here. So you can play with the settings using your app, your telephone app. And this also affects which pump you choose. In small children, sometimes parents do not wish their kids to have telephones or mobile phones, so they go for the T-slim pump. While others do not mind, so they use for the patch pump, and they can buy an app because it has to be a separate iPhone with the child and with the parent as well to do that. And some families have financial struggles; they cannot buy a smartphone, so they go for T-slim, while others can, so they go for patch pump. So as I say, and I always say, it's always a shared decision, and it's different from patient to patient. This is the whole point: is individualization of care. So you have so many options, and you individualize your treatment to that specific patient to make sure that they have the best management they can have. This is the idea of having the pump. So back to that. So patch pumps with these pictures, they are temporary, and they usually need an application to navigate the system. Tethered pumps are permanent, and the cannula is the part that needs to be changed, and they house all the control buttons in the device like a T-slim. We talked here about the advantages of having a pump. It improves HbA1c, time range, and psychological health of the users. But can you think of any downsides of having a pump? Yeah, pump failure, technical, no long acting, very well said, yeah. Not all families like them, can be disconnected. So yeah, you're absolutely right. Is there fail-safe measures to check in case of intentional drug overdose? Very nice question, Adele. I'll come to that. So as you've correctly said, infusion set failure. So if the pump fails, bear in mind you only have the short-acting insulin, the bolus insulin. So if the pump fails, you have a tendency to have acidosis very quickly if you're having a meal, if you had a meal, if you're sick or for any reason, because you don't have this nice long-acting insulin cover. So pump failure, it usually alarms, but not all the time. Sometimes it doesn't. It needs care. As I say, take it off when you go for a bath, take it off when you go for swimming, look after it, keep it clean, etc., which can be really challenging in small children. Interferes with activity. Sometimes the pump slips. The T-slim has to be carried in your pocket or sometimes in a waist bag or anything, so it doesn't interfere with activity. Sometimes it can be too much to handle. So avoiding information. Now back to the question about safety measures to make sure it doesn't give any further insulin. Yes, there is safety measures in the applications you have for each pump. You can limit the maximum delivery dose of insulin, so they cannot go above that. So regarding the basal insulin, let's say if someone's basal rate is 0.5 units per hour, or it's usually much less than that, like 0.25 units per hour, you can set the pump not to give more than 0.3 units per hour. So that's one of the safety measures. So they can't have too much insulin. The downside of that, if the pump cannot give above that limit, and the child is having a bad day, like a sickness day or something, then whatever above that, they will have to give us bolus insulin. Does that make sense? So there's always a downside of everything you put in a pump. So you can always limit how much pump can give, but then they will run a high risk of running hyperglycemia and acidosis if they are sick, if they're having a missed dose, or if they're having a big meal, etc., etc., etc. And the other way around. That's one measure. A second measure is there's always a shared app. So an application, the child will have the phone, let's say a 7 years old child, and the parents can view the app and can view all the changes and can do all the changes as well. That's a second safety measure I can think of now. I hope this answers the question. And they are expensive, but with NHS, it's not the issue, isn't it? So, but now there's this problem of pump, and if you are given a pump, and in the follow-up, you are found that it's not helping you and you're not using it, you're taking it off, and because we can see all of that in the application. If you are taking it off very often, if you're disconnecting it and you're running high blood glucose, you run at risk of it being taken away from you to another patient, because they are expensive and they have to be connected to the platforms almost 24/7 to upload the data. If the software failure happens, it usually alarms. You contact the company and they replace you with a second pump. So what I'm trying to say is no intervention is easy sailing. Every intervention comes with its downsides, and within the pump, every change you do comes with a downside as well. So you have to really think through what you think the best is for your patient and what good you're doing to them and what harm they run a risk of with this intervention you do, all in discussion with the witness nurses, dietitians, and the family. So what is hybrid closed loop system? So hybrid closed loop system basically is you have a glucose sensor that takes the blood glucose level, send that to the pump. Sorry, glucose sensor takes the level, send that to an algorithm, and the algorithm, by algorithm I mean either the application on the phone or in the T-Slim, the pump itself, the device, the smart part of the control unit inside the pump, and this tells the pump how much insulin it needs to deliver, and then 15 minutes later the cycle repeats itself. So glucose reading, glucose level, algorithm orders the pump, insulin is prescribed, and cycle repeats itself. This is the idea of hybrid closed loop system, and it's why it's called artificial pancreas, because you have a system in place, take the blood glucose, and you have a system in place to deliver insulin, and these two systems are talking to each other. Okay. So to best understand how closed loop system works, let me just take you through the platform apps we use for patients. So if you have a patient who's a closed loop system, let's say if he's in G6 sensor and Omnipod 5 pump, when they come to clinic, the platform looks something like this. So this is the main screen you see. So on your right hand side here, you can see that the insulin being given, and you can see it text in terms of basal and bolus. So that's how much basal they're having. This is how much the pump is giving anyway in the background. It's how much insulin is being delivered as bolus with each meal with the pump. And this is the total daily insulin, 17.4 units in the day. So this gives you, this is the patient's total daily dose of insulin, 17.4 units per day. This will result in this. So here is a display of the readings from the sensor. So it tells you how much percent the patient is on target, how much is high, and how much is low. So it tells you all the information that. And in the right bottom hand side, it tells you how much the pump has been on. So automated mode is when the pump is in the closed loop system. So this is 100%. That's a model patient. So most of the time, all the time, the pump has been attached and the pump has been working. And for the pump to work efficiently, you have to have a near this figure. And the manual mode is when the pump is off the closed loop system and it's just delivering insulin just like any other insulin device. And this is 0%. So we look at that to see how compliant the patient is with the pump. We look at that to see how much insulin is being delivered. And we look at that to see what's the result of this. Does this make sense? Then the next screen is how the actual system works, how actual closed loop system works. So let me ask you, what do you see in the chart? What comments do you have for the chart you see in front of you? Any comments, anything? Shall we proceed? Yeah, CGM medicine is delivered. Okay, thank you, Mohamed Ahmed. So this is how it looks. So you can see there's 4 or 5 levels of readings. So this top bit is tells you about the glucose levels. You can see top, you have the time from midnight to midnight, basically. And this is the blood glucose levels, how they are. And this is every dot is a reading from a CGM and gives you this chart. So it tells you about blood glucose. And you can see that when this patient goes to bed at 9, the glucose is very nicely controlled between 5 and 10, all through the night until he wakes up. And then things start to be messy, especially at the evening. So this is the trends we're talking about. These are the trends we're talking about. So basically, this patient, basal insulin is fine because his basal insulin is the one that's running in the background, whether or not you're having without any input from you. So his basal insulin is fine because his basal insulin is working. It's keeping him in range. But his bolus insulin needs some adjustments because once he wakes up, once he eats, once he gives insulin, things start to be a bit messy. And this is only one day. Usually this is a one-day presentation, as you can tell from the time. And when he goes to bed, everything goes back in range with some hypos, some hypers here and there. Second level, these squares you see is the carbohydrate he's having. So basically, in that particular day, this patient had 4 meals, 20 grams, 40, 30 grams, and 55 grams. And you can see that with this, you see a spike. With this, you see a spike. With this, you see a spike. Not pretty much with this one, but from that range up to that range a bit. So this tells you about the carbohydrate he's eating. This is how much insulin he's having. So that's the bolus insulin. This is the bolus insulin. So he's having a bolus here, a bolus there, and a bolus there. Now, this is a screenshot of the application, the platform. Usually, in the real lifetime, when you hover over this, it pops up and it tells you how much units has been given, what's the ICR at the time, and even more information about that. The bottom thing is the pump activity. That's the basal insulin. So this pump has been delivering every purple, like light purple is the insulin giving insulin, is the pump giving insulin, and the red dashes you see is the pause. So the insulin the pump stops giving insulin, gives insulin again, stops giving insulin again, and that's every red dash is the pump stopping giving insulin. Now, reading all of this together, what you think about the pattern of this patient. So it tells you, as I say, when the patient goes to bed, everything is fine. Now, here, this is the first meal. So he thought to have a breakfast. So he gave the pump order to give insulin, and he says he's having 20 grams of carbohydrate. And he asked the pump to give the bolus insulin that it's delivered. But then afterwards, the blood glucose went high and went high again. So then it went down. And then he had lunch, asked the pump to give insulin. It went up, went down again, and then the same here, and then the same here. If you have a clear eye and you've noticed, you see that the insulin and the meal are given at the same time. So at the same time, you had the carbohydrate dose and you had the insulin dose. While the recommendation is to give insulin 15 minutes before you have your meal. So when you see that, you can tell that the patient had the meal in front of himself, started eating, then he said, oh, I forgot. So he asked the insulin to deliver. As a result of that, you have the spike because the insulin is lagging behind, delivery is lagging behind. So the glucose goes up before it goes down again. And you can see this very clearly here in the evening meal. So this one, first of all, the blood glucose went up and no insulin was given. So the only reason why your glucose can go up like that is if you had a meal. So I assume he had a meal here and he has not had any insulin for that. So blood glucose went up. Then he had a meal again. But with that meal, he had the insulin at the same time. So it went down, it went up because of the meal. Then the insulin kicked in later without carbohydrate cover, and it shifted his glucose down before it goes back up again. The message, there's too many messages you can get from this diagram, but the important message is to know that when your blood glucose goes high, this is because you had a meal. Hi, sorry guys. Can you hear me?
Yes, we
Yes, we can hear you.
Sorry about that. So the first message to take from this diagram is when you have a meal, and you tell the pump to give you the insulin, it has to be 15 minutes before. Otherwise, you can see that the insulin goes up and goes down again. So to prevent this spike of insulin, of blood glucose, insulin has to be given 15 minutes before. That's one message. Second message is when the blood glucose trends down, when it goes down, do you see what the system does? It stops giving the insulin. When it goes down again here, it stops giving the insulin. And this is the closed loop system working. So the CGM is having a reading that blood glucose is trending down, stop giving insulin, stops giving insulin. Blood glucose has stabilized. It restarts giving insulin. Then it goes down again, and this stops. And this is how the basal. This is the role of the AI, of the closed loop system. But it's a user fault because number one, insulin is being given after when it's supposed to be given. And this makes me question, is this insulin enough? Because with that meal, yes, you had the insulin a bit late, but you still continue to be high for some time. And when you had here, you remained high for some time. So likely, this patient needs more insulin, which makes me thinking about maybe I need to increase insulin carbohydrate ratio when I see them in the clinic, at least for the evening meal. Does this make sense, guys, or is it too much?
May I ask a question?
Feel free to ask questions, yeah.
Giving insulin was this
What's the question, sorry?
basal. Why the pump stops giving basal insulin when the glucose is so high?
You mean in this, where? Here.
In this,
It is high, it's trending down. So the pump works on the predictive insulin values, not the actual insulin values. It works on the trends. So when it was spiking here, it was giving insulin. But then, because the base at this point in time, do you see my pointer?
Yeah.
At this point in time, there are two insulins on board. There is the basal insulin working and the bolus insulin given. And this helps the blood glucose to go quite rapidly down. As it's going down, the pump reads that if it continues giving the basal insulin, it will even go further. So it stops giving the insulin here to prevent hypoglycemia. It restarts once it has stabilized, but then there's a dip here, so it stops giving here. So the pump basically stops giving insulin when there's a risk of hypoglycemia going in. And these are all alarms you can set in the system. So you can set your target between 4 and 11. So if the blood glucose is trending below 4, the basal insulin stops. So unless you give insulin to override that, the pump will not give any insulin until blood glucose stabilizes again, and then it restarts giving insulin again. I hope this answers the question. And you can see this very clearly here. So the blood glucose was very high here, then it went steeply down. Then the pump just stopped. And you can see that even the pump stopping did not prevent this patient to have a bit of hypoglycemia here and there. Then he had a meal, then it went up to the baseline again. Then he went to sleep. When he went to sleep, pump took over and maintained blood glucose tightly and nicely controlled until he woke up again. Does this make sense?
Yeah, thank you.
So probably you won't come across this. And this is an outpatient kind of intervention. But I just brought this in just to give an idea about how, in real life, the closed loop system works to help maintain the blood glucose. I think I have another chart.
Question, Mohammed.
Yeah, go on.
Seems like this pump is mostly working just like morphine pump for the breakthrough morphine in palliative care patient, but the only difference which I am perceiving here that this pump is receiving like auto receiving the blood glucose level based on patient's dietary intakes and then adjusting the doses automatically for the bolus insulin. Am I right?
No.
No.
You're partly right. So the pump does not know how much carbohydrate you're having.
Okay.
But if you tell her how much carbohydrate you're having, it does the
Okay.
math for you. So let's say,
Okay.
for example, for the breakfast, if your insulin carbohydrate ratio is 1:5,
Hmm.
and you're having 20 grams,
Hmm.
you tell the pump, I am having 20 grams. All you have to do is tell the pump, I'm having 20 grams of carbohydrate. And the pump auto-calculates that 20 grams with ICR of 1 to 4 means 5 units, and it gives 5 units.
Okay.
Okay,
So
but you have to tell the pump, you have an essential skill you have to learn, as if every day person has to learn, is how to do carb counting, how to count how many grams of carbohydrate his meal has. And then he has to tell the pump how much he's having, and the pump does the rest.
Okay, yeah, that's the reason I think here at 6 o'clock, like 18, the carbohydrate intake is 30. Yeah, this one. So the like it seems like blood sugar is going pretty high and carb is 30, like carb intake. So
Yeah.
it's meant like this carb intake is feeded manually.
It's feeded manually, which this is why I think you see this spike here. This cannot happen on its own. This patient did have a meal here, but failed to enter this to the system. So
Yeah.
this is what this is the important, because we show them the charts when they come to clinic, and we say, look, your blood glucose went up here on Thursday at around 5 p.m. Do you remember that? So what happened? And he'll be like, yes, I went out with friends and I didn't put my insulin in. Because this here tells me that this patient did not enter his carbohydrate. This is why he has not had insulin. This is why blood glucose went high and remained high for some time. If you see a pattern, if you imagine with me, if you see a pattern here, no carbohydrate entry, just insulin delivered. Then you assume that's a correction, because we give correction without carbohydrate, and then it comes down. But no, it did not have a meal. It went up, then had a second meal. It remained high, and then he remembered, put the insulin, but it's too late. So he has two insulins on board. He has the bolus insulin and basal insulin, so it shifted down again.
Okay.
So it has to have a bit of a critical mind to understand this. And it's not only one, this is the 1 day. Usually we rely on 2 weeks readings to make decisions. So it's not only one bad day, because you can have a bad day.
Yes.
But it's patterns you're looking for and fixed behaviors you're looking for to change and to achieve, and then make decisions based on that.
Yeah.
But it just tells you how beautifully the glucose and the pump work together, and how the user can either help the situation or make it even more difficult for the system to work.
Yeah. Thank you, Mohammed.
You're welcome. Any further questions, guys? So I have a question. Why it appears as if there is 2 lines for the glucose readings on the chart? You're right. It's not usual, but sometimes because of the system overlay, it gives you overlay of the system of the readings of the same day. But it's not something that we see most of the time. And in such a day, if I have 14 days option, I might go for a different day to make a decision. But I just brought this particular day up because it just tells you how the system works together. But you're absolutely right, Mohammed Noor. So it's usually 1 line that tells you what's going on. But usually this is unusual because of the system reading, maybe the sensor reading. What is continuous green line at 6.1 millimole if the target glucose? Why is 6.1 specifically? Yeah, so 6.1 is the target blood glucose. It is. Why specifically? Because that's what the companies advised us to choose. So different companies they just advise different levels. 6.1, I think this is an Omnipod, and 6.7 for T-Slim. But we can change that. And this is for this patient specifically, because probably we start at 6.1, and then we can change this. If the patient comes up with a high, okay, let's just first define what is a target glucose. Target glucose in closed loop system is the glucose above which the system must correct. If you remember what I told you about the basal insulin can either be increased, decreased, or stopped as per the closed loop system. So 6.1 is what you give the system to say, this is your target. If the blood glucose is 18, correct it down to 6. If it is hypo, stop insulin until it goes back up to 6. So this is the definition of target blood glucose. 6.1, as I say, is the default by the system. But if I have a patient, which I'll come to, okay, in the next slide, is running basal high blood glucose, I want a tighter glucose control, I can change this from 6.1 to 5.9, for example. And the other way around, if a patient's target is 6.1 and he's so tight on the line, sometimes he have hypos, I can bring this target up to 7.5. So that's the idea. And for this patient, because probably it just suits him, but it is changeable and it can be changed. I hope this answers the question. Any questions, guys? Another patient, not a very good day. Tell me what you can see. Feel free to use the mic, guys. Any volunteers? Shall we proceed? So, Abdul so in the closed loop, I only enter the carb amount, but I don't have to press anything to give the bolus. Is that right? Yes, that's right. So you just tell the pump how much carb you're giving, and then you press confirm and give, and the pump does the rest. It does the calculations, and it does give the insulin. Sarah Saadallah, high glucose levels and hypos, you're right. Any more input? Any more ideas? Both basal and bolus readings are impaired. Yeah. Bad control, absolutely right, Inas. Fluctuating, yes. High blood sugar most of the time. Concern about pump failure as well. Yeah. So you're all right, guys. So we always look for patterns. So this patient, the first thing that strikes me is having very wide range of blood glucose readings. So, sorry, just let's look at the chat. Someone is not enough basal insulin, high blood glucose most of the time. Yeah. So yeah, so this one, sleep or awake, blood glucose fluctuating, especially when he's having some meals. So this one is the first meal, likely early in the morning, has 75, then had some insulin, again, insulin at the same time of the meal, not 15 minutes before, but he did have this as well. So he asked the system to give two insulins, and I don't know why. We have to ask them. So why? But this is unusual to have two bolus insulin for the same meal. But so just one second. Yeah, my battery was running low. Sorry, so I put it on. So then had a meal, spiked up again. Had another meal, some insulin, spiked further. Had another meal, before coming down again and going into hypo. So with meals, it's spiking very, very high. And with meals, it goes up high again and probably goes high up again. Probably this one ate before they go to bed. Here, this is why it went high. So this patient have a poor control. And you can see the target here is 7.27, a bit of higher. And I assume they put a bit high because he was having some hypos. You can tell here that whatever insulin he's having is not enough because he spikes afterwards and he eats, then it spikes further. So for this patient, given the information that we've discussed in the previous slide, I would change all of these ratios and put them a bit up to give him a bit of higher insulin. And I will change his basal insulin as well. I might bring this from 7.27 to 6.9 for a tighter control of his basal insulin. So if I see this patient in the clinic, and again, bear in mind, this is not based on one day, you have to look for patterns, look for several days. And if this happens to be a fixed pattern, what I would do is I would bring down his target for tighter basal control, and I would change all of these ratios to give him more insulin with his meals. The hypo here, likely because he had too much insulin, they all work together along with the basal insulin, and then he had a hypo. If we prevent this hyper, we'll secondarily prevent him going to hypo because he will not go high to go low again. So it's basically his breakfast meal, his lunch, probably this is just a snack, his lunch, and his tea time ratios all need to be adjusted to improve his hemoglobin control. So variables that can change, we can change for optimization of the blood glucose level in the closed loop system. As we have discussed, insulin carbohydrate ratio, just like the last slide. So we can change this to give them more insulin. Sensitivity factor, if they are correcting, but the blood glucose is not coming down in range, you might need to think about changing the insulin sensitivity factor. Or the other way around, if they have a high blood glucose and then they have a correction and they run into hypo, maybe you need to go a bit more liberal on the correction of the insulin. Basal insulin, as we discussed, and sometimes you need to change the target blood glucose, which are, these two are related to each other. So if you change the basal insulin, you change the target. And I put them both here because, for example, in the T-Slim pump, you can change the basal insulin. You cannot change target blood glucose. While in the Omnipod pump, you can change target blood glucose, but not the basal insulin. But they are both the same. Basically, you're telling the system, can we please give more or less insulin, please? But it's based on the company. Sleep and exercise mode, which is very interesting. So there's two modes. I'll just go through them quickly because it's more of a specialty kind of topic to talk about. It was found that your exercise increases your insulin sensitivity. So if you go to let's say if a patient is going to have a swimming, okay, not swimming, but he's going to have to play football or play rugby or whatever, we ask them to put the system on the exercise mode, which reduces your basal insulin by 20%. So it delivers less insulin. And the reason is because while you're exercising, this less insulin will work just as efficiently as the back basal rate. And once you finish exercising, you go back again into the normal mode. This is the exercise mode. So it reduces the basal rate by 20% because you are more sensitive to insulin when you are exercising. The sleep mode does the opposite. So the sleep mode basically is to prevent overnight hypoglycemia. Okay? That's the same basically. So it's to prevent overnight hypoglycemia, low blood sugars. So when you go to sleep mode, your basal blood insulin delivery goes down a bit to prevent you from going hypoglycemia. So these are the two modes that you ask them sometimes to put on. And basically, but that's more of a specialty kind of special advice. But basically, ICR, ISF, basal insulin, target glucose, and sleep exercise modes is what we change usually when you see the patients in the outpatient clinic. This patient is from a different platform, but it delivers the idea. This 3.9 to 10. This is the range. And this is where the patient is. Can you see that? So most of the day, patient is high. If there is one thing I need to change about this patient, is I would change his basal insulin. So to shift this line from up, down into the range. So probably if this patient goes up in the basal insulin and this whole line drops down, he will be in range. That's an example of a patient who needs to change a change in his basal insulin to bring down glucose in range. Does this make sense, guys? Yeah, you're right. We don't give long-acting insulin with a pump. No, we don't. Any questions? And there's just a quick review. There's more details onto it, and there's more technology into it, and there's more kind of new information into the whole closed loop system. It's all clear. Let's go through the on-call diabetes survival guide. And I will really need you to be interactive with this, guys. It's a scenario based. So feel free to use the mic if you wish, so we can have the maximum discussion and the maximum use of this presentation. So let's talk about hypoglycemia. So you either call pediatric registrar, you receive a call from a concerned mom of Charlie. He's a 5-year-old boy who was diagnosed with type 1 diabetes 6 months ago. He has been having cough and low-grade fever for 2 days, and his appetite is not great either. He has Dexcom 6 sensor and is having multiple daily injections and long-acting insulin. This evening, his blood glucose would never go below 80 millimoles per liter. She's asking for advice. So if Charlie, 5 years old, having injections, and he has a sensor, Dexcom 6 sensor, I'm most concerned that on top of his illness, his blood glucose is 18 and it's never coming down. What more information do you want to know?
His ketones.
Yes, ketones.
Is he vomiting? Is he not tolerating oral intake?
He's fine. He's not vomiting after every feed. He has a bit of a vomiting, but he can take some.
And is the glucose checks from the monitor from the Dexcom, or is it finger prick? How they done finger?
Yeah, that's a finger prick one. The 80 millimoles is a finger prick one. So Amrat, yeah, no questions given yet. She's just calling because she's worried. She doesn't know what to do.
How much his weight?
No, it doesn't. Let's say he's weighing 18 kilograms.
What is his total daily dose usually? And
yeah, so yeah, you're getting the gist of it, guys. Yeah, that's the questions we need to know. Yeah, very nice. So yeah, I'll give you more information as we go along. Then we'll see how we can manage him. So yeah, no vomiting, abdomen pain or lethargy. I'm asking this because whether or not he's in DKA. His ketones are 1.1 millimoles per liter. His ICR is 1 to 25 for all meals. He takes about 6 units of short-acting insulin per day, and his receiver dose is 4 units per day. So how would you advise her? So yeah, thank you guys for sharing. So you've thought about the right questions. So the first thing you have to ask about the ketones, because it does really tell you where to go from there. And a bit of a background, whether he has a DKA, symptoms, can he take orally or not, what's his current insulin regime that he's on. So let me introduce you to the sick day management protocol as per our local trust. This might change as per the trust you're working with, but the idea is basically the same. It's a traffic light system, green, yellow, and red. This is for patients who's having more than millimole, 8 millimoles, and having ketonuria, or blood ketone 1.5. Always think about DKA. Always think about DKA. And if you are in doubt, just consider it as a decanted fluid. Otherwise, ask them to go to ED. Based on your ketones, you can go either mild, moderate, or severe, less than 0.6 is normal, up to 1.5 is moderate, more than 1.5 is red. And then just feel free to just read through it. It's a very nice guide. So if they are fine in the mild category, no DKA symptoms, and they look fine, you just give them correction dose. Just ISF dose, and then you repeat the blood glucose in 2 hours and see how it goes. If their ketones are a bit high, which is our friend Charlie here, his ketones are 1.1, okay, you have to give him some extra dose of short-acting insulin, 10% of the TDD. Okay, and if you are in doubt, let's give them 0.1 units per kilogram, and then repeat the blood glucose in 2 hours. If they fall into this category, basically, they are at high risk of having a DKA. So you give them double that, you give them 20% of the total daily dose, or 0.2 units per kilogram, and then you repeat that in 2 hours. But the idea is never stop giving insulin for their meals. That's the key message. Based on that, our friend Charlie lies in the yellow category. Do you agree? He's not in DKA, and his ketones are 1.1, and he's sick. So this is sick day management. So there's some chat messages. So give him the short-acting insulin to correct. Okay, so his ISF is 100 by 10. Total daily dose is 1 to 10. That's his ISF ratio. 1 unit decreased by 10. So I would give him the correction dose and repeat the blood glucose in 2 hours. And preferably, because these are all estimates, check the latest clinic letter if you can access that. Obtain his total daily dose from that and wait, and then you can do the calculations. But the idea is he's not in DKA, he can have the subcutaneous insulin at home, and he can call you in 2 hours and let you what the results are. Does this make sense, guys? She called 2 hours later. He started vomiting, and he's more lethargic. And the repeat blood glucose is now 19 millimoles, and the ketones are up to 1.9 millimole per liter. How would you advise her?
Bring her to the hospital, A&E.
What do you think? DKA, yeah.
DKA.
That's the key message. So if the blood glucose is going up despite having the insulin, and they start having symptoms of DKA, just have a low threshold, say, look, we'll check you over, let's come across.
Would you advise for another correction on before coming, like on the way?
Not if he is vomiting and is more lethargic. On the way, you mean?
Okay. On the way.
On the way to any, yes, you can ask them to give a correction on the way to any. But they should not delay them coming to any. about the double correction, the 20% dose, you can do that, Muhammad. You can give them the 20% correction dose subcutaneously and come to the NE. But with the rising ketones, the key messages just come to NE to see that whether or not you have a DKA. If they come to NE, they have a blood gas and they're not in DKA, then you can do the correction 20% extra subcutaneously. And then you can repeat the blood glucose in 2 hours. So, at the start of your Saturday, this is one other scenario. So at the start of your Saturday shift, you were approached by a nurse in PAU who informed you that a concerned mom of type 1 diabetic patient is on the phone. Her daughter Aisha is 15 years old, who has had diabetes for 6 years now. She was started on the hybrid closed loop system a month ago. She went out with friends to a local party. She has just come back from her blood glucose is 22 millimoles per liter with ketones of 1. Aisha is well in herself. Mom tried to correct this high glucose once, but it remained the same. What else would you not want to know? And I'm asking what else you want to know, because these phone calls never have all the information that helps you to make a decision. So don't rush always to make decisions. What I do usually is I say, look, go back to mom, take her phone number, her child's name, date of birth. I'm a bit busy now because you're always busy when you're on call. Okay. And I'll call her back in 10 minutes. So I have all the details. I look into the system. I read the background of the patient, the last clinic letter, what's happened, any concerns about control, what's going on. I have a plan in my head. I even sometimes open the guidelines in front of me. Okay. And then ask them. And most of the cases, it's more of a telephone, real-time advice. You'd be like, have you checked her ketones? I'd be surprised how many parents call without checking the ketones. You'd be like, no, okay, can you please check the ketones now and let me know? And then you go on and then you advise them. So with this particular scenario, what else would you like to know? Yeah, her carb intake. What is pen correction? Yeah, no, it was a pump correction. Aya, Abdulati. It was a pump correction. Alcohol, yes, you'd like to know that. Absolutely. Medications, how well she is. She's well in herself, Abdul. There's no vomiting or being unwell. With the alcohol, maybe alcohol runs the risk of hypoglycemia rather than hyperglycemia, but it's always good to think about. She is on the pump, Iman. So the pump just only gives short acting. So she was giving short acting corrections. Mom was giving short acting. So the correction mom gave was a short acting insulin via the pump. Pump works okay. Change of needle. Very well pointed, Christina. So the pump, no alarms on the pump. Okay. And the needle has been changed 2 days ago. How much bolus was given? Yeah, so you want to know that, because do not assume that all parents know how much the correction of the children is. So I want to know how much correction was given and how long ago. How long ago is essential. If you had a call 30 minutes after correction has been given, and the parent says that, oh, I don't think it's working. No, just give it 2 hours. So we rely in reading after 2 hours, given the patient is otherwise well. So it's every 2 hours reading. So how long ago was given? If it's given 2 hours plus ago, ask for another correction. Or if it's given less than that, just ask for just sit tight and watch and see how it goes. And I want to know what's her total daily dose. her correction ratio, and has there been any recent changes? And I will go to the clinic letters and see how it goes with her and how much she was on before I make any decision. So all of this information, with all of this information, if we answer that she was given the bolus 2 hours ago, mom gave the right correction through the pump, it was given through the pump, and total daily dose is in the pump system, and mom gave it to you, and there have been no recent changes. So then you advised a second correction with the pump 2 hours after the first one, as per your advice, but 2 hours later, blood glucose remains 22, and her ketones are now 1.2 millimoles per liter. She continues to be well in herself. Yes, Mohamed Noor, pen correction. So you should consider pen correction. And why is that? Because of Christina's question, pump works okay or not. So now, if I have a patient in closed loop system who's had 2 corrections and insulin and the ketones are rising, glucose is not coming down, the first thing I question is the pump working? Especially knowing that she's been on the closed loop system only a month ago. So I don't know how much confidence is there with dealing with the cannulas change, cartridges, reading the alarms and everything. So what I would consider in this scenario is cannula displacement, tubing blockage, or pump failure. Because if insulin is in her system, in her blood, I expect to see a change regarding her blood glucose and ketones level. And how will you address this issue? As Mohamed Noor said, revert to injections, receive another correction, repeat glucose and ketones in 2 hours, and most importantly, advise to have receiver. Because remember, the pump patients do not have the long-acting insulin in their system. And if she goes to bed having only the correction, okay, if she's unwell, she runs the risk of having hypoglycemia overnight. So make sure that she's covered with receiver. And every patient, again, as per the RCPCH guidelines, has a pump. They do have both short-acting and long-acting insulin that should be checked regularly for expiry date and should be with them wherever they go, because you never know when the pump is not going to work. And the right-hand side is again the 6-day rule. You just make note of it. It makes your life way easier if you have it in your hand to guide you about how to advise patients over the phone when you're on call. The take-home points of hypoglycemia is cause of high blood sugar are not enough insulin that they're having, no insulin at all, they're not having insulin at all, expired insulin. Think about that, especially if patients are having pumps. The insulin cartridge in the pump needs to be changed, and the pen as well, needs to be changed every 3 days. And if it's been more than 3 days, whatever insulin is being given is ineffective or less effective. Sickness, they're unwell, and failure of insulin delivery. For injection patients on MDIs, it could be lipohypertrophy, or for patients on pump could be obstruction of the tubing or pump failure. Always check for decay and consider switching patients on pumps to MDI if they are struggling. Always communicate your emergency plan to the diabetes team, who takes on the next morning by email, special paperwork, or ask parents to call the specialist nurse. And calculations, bear in mind, calculations of TDD and correction dose are all estimates. If you have the most up-to-date data from the most recent clinic or pump settings, this probably is more accurate.
Thank you, Mohamed.
Are we approaching time, aren't we? That's a bit comment of my side. So I don't know how you feel about proceeding. I think we have 5 minutes. No, less than 5 minutes even.
Okay. If everyone, I think it was a very interesting presentation, to be honest. It was very informative. So yeah, we can proceed.
I don't know what you think, guys. I don't know how people's.
Yeah, we can see in the chat. Yeah, I think everyone is happy to proceed.
I apologize, guys. Not a very good timing of my side, but I think it's just we're just taken away. So hypoglycemia. So probably that's a more straightforward thing. So while you are on call, and then a SCT doctor called you for advice, she's seeing Jack, who's 8 years old, known to have diabetes, and is having insulin injections. He came to NE with 2 days history of vomiting and diarrhea that she thinks is gastroenteritis. His blood sugar is 3.2. He does not have any symptoms of hypoglycemia. He's asking for advice. So when she says he does not have any symptoms of hypoglycemia, to assess that, let's ask the question, what are the symptoms of hypoglycemia that you can think of?
Lightheadedness, sweating, feeling of hunger, tremors.
Yeah. So it's always good, to assess that subjectively. Don't take the word, oh, no hypoglycemia. Just ask more questions to understand, because this will change how you manage the patient. So autonomic, hypoglycemic, and behavioral, there's tons of them. Pallor, feeling hungry, confusion, in severe cases, seizures and unconsciousness, sometimes just irritable, or maybe just feeling nauseated, or being a bit aggressive, sometimes can be hypoglycemia. What is the definition of hypoglycemia? Biochemically, 4 is the floor. Anything less than 4 millimoles per liter in diabetes patients is hypo and needs to be treated. Let's make this very clear, because there is different cutoffs in practice. There's neonatal one, there is gastroenteritis one, and there's ones that just goes by the mood of whoever treating the patient. But with diabetes patients, it's 4. 4 is the floor. Anything less than 4 is hypoglycemia. Whether it's mild, moderate, or severe, it's a different issue. It is hypoglycemia. So what would be your advice? So basically, it depends on whether he can cooperate to take orally or not. He's 8, bear in mind. If they can take orally, you give 10 to 15 grams of fast-acting oral carbohydrate. Every patient who has diabetes, they do have a hypoglycemia plan in place, and they do have a suitable fast-acting sugar-containing thing to have, either dextrose gel, dextrose tablets, okay, or Lucozade, or whatever suits them. They do have this in the bag. They carry on with them, with the insulin pens, the glucose meter, the ketone meter, and hypoglycemia treatment. So this should not be an issue. They should have that. So depends on the choice of the patient. They can either have dextrose tablets, Lucozade gel, if they can't take that, or glucojuice. And approximately, they need 9 grams of glucose, 0.3 grams of glucose for each kilogram they weigh, just as a rough estimate. So you give them that if they can take something orally. If they can't, because he's vomiting, bear in mind, he's vomiting and he's nauseated and he thinks, I don't feel that. And the glucose tablets, to be honest, they taste awful. I don't know if some of you have had them. If an individual is not very well, they might be very reluctant to have them, especially if they've had them before and they know how they taste like. If they are reluctant, then give them glucogel just at the cheek, either half tube or full tube. Put the blood glucose, then you repeat the blood glucose in 15 minutes. And then you assess. So I gave her that advice. He can't take orally. He said, okay, let's give him 4 tablets of dextrose tablets. He had that. And in 15 minutes, you reassess. If blood glucose is more than 4 millimoles, i.e. hypoglycemia has resolved, then you have to give them things to maintain this complex carbohydrate meal. Okay. One more tip about this. Patients who are on the pump, bear in mind, this patient that is on injections, If they were on the insulin pump, you don't do this. You omit this dose because you just don't give them a carbohydrate meal. Correction, that's it. Then the system takes over and maintain the insulin. And when he has his next meal, just as normal, he'll have his ICR with that. But if they are in injections, because they have the long-acting insulin from last night, give them this complex carbohydrate to compact the action of the long-acting they've had from the last night. I hope this makes sense. So this Jack will have a complex carbohydrate because he's been on injections. If he was on the pump, he wouldn't have this. He wouldn't need that. If it's less than 4 millimoles per liter, you repeat the steps again and you ask the question again, can they take orally? If yes, give them that. If they can't, glucogel and do it in 15 minutes. As for this Jack, she calls again. He so far had 2 oral attempts to correct his hypoglycemia, but he vomited the second glucogel and is now drowsy. His blood glucose is now 2.1. It was, what was it when he came in? It was 3.2. Now it's 2.1. What would you do?
Child needs IV correction, so child needs to bring in A&E.
He's in NA.
Okay, then IV correction now.
Yes, IV corrections, because he's now turning towards the severe hypoglycemia. So yeah, everyone who responded really nicely and in time. So you give glucagon, intramuscular injection, or subcutaneously to the thigh. That's number 1. And you give the IV correction. So 2 ml per kilogram of bolus. And if they are suffering with continuous hypoglycemia, just give them a infusion, 2 to 3 ml per kilogram per hour, but always discuss with diabetes team before you do that, because they also run risk of what's called rebound hyperglycemia, and we just zigzagging his glucose, which is not very great, and it runs the risk of brain damage because of the unstable glucose levels. So give glucagon and give bolus of dextrose, and just stop there and discuss with the diabetes team whether or not he needs to be in infusion if his hypoglycemia is resistant. Then check blood glucose to 5 minutes, 15 minutes, and half an hour until it's stable. Then you go back basically a step back. If it has corrected with this treatment, glucagon and IV correction, if it's more than 4 millimoles and he can take oral fluids, just let him offer clear fluids. And once this is done, give him more complex meal to have. Then sit down, and this goes for hyperglycemia as well. Sit down and try and identify the reason of hypoglycemia. The most common reasons of hypoglycemia, as with this one, is either they are not taken orally with the vomiting, being nauseated and not feeling very well, or sometimes having insulin and then not having the meal because of vomiting or whatever. So you have insulin on the system without the carbohydrate, so it does restrict your glucose down. Refer to the diabetes team for review, as you would do anyway with hyper or hypoglycemia, and advice and education. If he's still not improving, then he will need IV maintenance and discussion with the diabetes team. Also, it's good to consider other causes of drowsiness. An AI, head injury in the history, which is unlikely, but people tend to forget about adrenal insufficiency. Autoimmune adrenal insufficiency is one of the associations of type 1 diabetes. They are both autoimmune, and it can present as hypoglycemia, and it will not correct until you give them the hydrocortisone. So always just put this at the back of your mind, especially when you have hypoglycemia. What else? You have hyponatremia and hyperkalemia. Let's think about that as well. And does he need the hydrocortisone dose or not? But again, at that point in time, probably there's a multi-specialty involvement and the chronic diabetes involvement as well. That's my references. Any questions about hypoglycemia? Would you send hyposcreen if present hypoglycemia? Yes, you would, but if check the ketones, If it's non-ketotic hypoglycemia, probably it's just the insulin. If it is ketotic hypoglycemia, then by all means, yes, you do need to do that. I hope this answers the question, Mohammed Noor.
Yeah, thank you.
Any further question, guys? Good. So that's the references. The BSAPCH is a very good teaching source for diabetes, and the BSPD as well guidelines, they're all there. My tribute is to my senior, who passed away about a year ago now, with the war in Sudan. And it's just my tribute goes to him. And this is, inshallah, just for his sake, inshallah, for his ajr. Please make prayers for him. May he find peace, inshallah, in the hereafter. We lost him suddenly. He was killed in the war in Sudan that's going on now. Just one of the people who made a very gentle and big touch in all of our hearts, his students. Let's pray for him. And thank you for your time.
Thank you,
That's me
Mohammed.
done, guys.
Thank you, Mohammed. That's very useful. Thank you.
Yeah, thank you, Mohammed, for sharing
Thank you.
your experience and knowledge today. And thank you for your incredibly informative presentation. And also, I would like to extend a big thank you for all of you, the attendees, and for your active participation and engagement. It was really very impressive. As we wrap up, let's take a moment to fill the feedback. The link is already provided in the chat box, and kindly complete it so you will be able to get the attendance certificate later. Thank you once again for being part of today's lecture, and we look forward to seeing all of you in future events. Thank you so much and have a lovely day.
Thank you all.
Mohammed, kindly show me the slide for references. I missed it. Sorry for that.
Yeah, absolutely.
Thank you. Thank you so much. As a GPST, it was worth learning for me. I learned a lot. Thank you so much.
You're more than welcome. Thank you very much.
Thank you.
guys.
God bless you. God bless you.
Thank you. If there's any more questions, guys, before I leave,